So I'm Christina. I've been with the multidisciplinary clinic at Stanford for about a year, and it's a great group there. And I'm here to talk to you about CMT and breathing. I want to walk you through what a pulmonary evaluation might look like and why it is that you may ask for one or seek one out at wherever your home clinic is. Why do we breathe? Our bodies take in oxygen and they exhale carbon dioxide. So that's what's happening every moment for all the rest of our lives. It's something that most people, we don't have to stop and think about it, and that's as it should be. So you take a breath in, oxygen comes into your lungs, and it travels all the way down to the bases of your lungs, where you have your alveoli, and it goes across a membrane, taking oxygen to all the vital organs in your body, and then taking the CO2 that your body is producing and letting it back out into the atmosphere. So the mechanics of that you can see up here on this slide. We have our diaphragm, which sits right about here. It contracts downward. It's naturally a dome-shaped muscle. It contracts downward, and we have accessory muscles all along our chest wall or thoracic cavity that help pull the rib cage open. With that, a negative pressure is created inside the lungs, and air rushes in. Your diaphragm will then relax, turning back into a dome-shaped, pushing up and creating another pressure, allowing that air to flow out. So the Mighty Diaphragm, it does 70% of our work of breathing. As we said before, it's naturally dome-shaped. It also separates the vital organs in the chest, such as our heart and our lungs, from our abdomen. It's composed of skeletal muscle and tendon, and you can see in the picture above there are 3 openings within your diaphragm that allow other anatomy to go and travel up, such as your aorta and your phrenic nerve. And let's see if this works. I found this, what I thought to be very cool. Well, darn. Maybe I'll find a way to email it to everyone. But if you go online, it is a YouTube video, but it's a very cool video actually showing the diaphragm and its movement and the chest wall expanding. So we've got 2 components, right? We've got that diaphragm and these accessory muscles, and this does come into play later. Inspiration, when we're inhaling, is an active process because those muscles are flexing and moving. Your accessory muscles are inspiration. You can find your sternocleidomastoid and your scalene muscles right around here. So if you've ever seen particularly a small child with a respiratory infection, just a regular cold, and you'll see these muscles pop out here. And you'll also see it in adults. And that's when you're doing some extra work to breathe. And it might just happen when you're at the gym running. And then there's also other muscles in between the ribs. Your external intercostals and your internal intercostals can help you when exhaling. Now, although inspiration is considered to be an active process in your breathing, so your body is doing work, exhalation is passive. It should just happen normally. So again, here's 2 more pictures just illustrating the movement of the chest wall. I'm glad I have these since the video didn't work. Illustrating the movement and the chest wall and the airflow movement. So you can see over on my very far left is the oxygen coming in, carbon dioxide going out. You can notice the lungs expanding and then becoming smaller as you exhale. And as well as to my right, you can see how the chest wall and the rib cage is going to move up and out. So here we have a picture illustrating the lungs and then that mighty diaphragm. You can see how it's dome-shaped, its attachment points at the rear of the chest wall and in front. And then you'll see the 2 yellow lines coming down. Those are illustrating your phrenic nerve. So you have 2 phrenic nerves, one for your left and one from your right. And they come from C3 to C5 along your spinal cord. So these nerves are important because they are what innervates or starts that movement of the diaphragm. So if you've ever had the hiccups for a long period of time, that's your phrenic nerve that's sending that trigger down to the diaphragm and telling it to quickly contract, relax, contract, relax. So through the clinic, we took a look at 23 people that we've had in our clinic with CMT since March of 2013. And when people come into our multidisciplinary clinic, I have the privilege of getting to work with them and speak to them about breathing. So of those 23 people, 12 of them have CMT1A, 11 of them have another type of CMT, 14 of them were females, and 9 were males. We'll go over that bottom part a little bit more on another slide, but part of that time that I get to spend with those patients, we talk about your breathing and whether you ever have any issues with your breathing or any shortness of breath. And along with that, something that's important is other factors that can coexist with CMT that may make you have more symptoms of shortness of breath, such as scoliosis, a higher BMI, or history of asthma, sleep apnea, and COPD. So this is another breakdown of the patients that we looked at in our clinic from March of 2013. So the first column shows the type of CMT, and the second column shows how many of them showed pulmonary dysfunction. And by pulmonary dysfunction, what I mean is that on their FVC, or forced vital capacity, which is if you take a big deep breath in and then blow out as hard as you can until your lungs are all the way empty, that's your forced vital capacity, how much air you're pushing out. And so the standards say that if you're 80% below what the predicted normal is for your height and weight and age, then that shows some form of compromise. Many people are somewhere below 80%, 80 and 70, or between 80 and 60, and they might not even notice it in their activity of daily living, but that deficiency still exists there. This is an example of more data that I found in an article through the Tennessee Medicine Journal about phrenic nerve involvement in CMT and diaphragmatic weakness. Again, you can see here, they had 11 patients, 4 of them were males, 7 of them were females. In their study, I think they found that the majority of the patients that they found affected had CMT1A. However, I think that in the studies that I found, the majority of the patients that they had for those studies had CMT1A, so I think that could be part of the explanation for that. Most of the studies do find that there is not, actually let me take that back. I found both answers as far as whether there's a difference between males and females, and I think a lot of that just depends on how the studies are broken down and what the populations were that they had of the patients. We definitely need more studies to get more conclusive data. There we go. So age at diagnosis and the duration of disease had no correlation. So going back to those contributing factors, diabetes also can cause neuropathy, so that can increase the effect of having neuropathy and that neuropathy coming into play with the phrenic nerve and the diaphragm, and also your other accessory muscles of breathing, right? So your diaphragm is doing 70% of that work, but if your other muscles that take care of that 30% are weakened and not able to help out, then if you're put at any respiratory stress at any time, then you might feel that difference. Other complications that can add to that are kyphosis or scoliosis. So on the bottom right over here, you see a picture of a normal spine and then a spine with scoliosis, so that curvature, or kyphosis where that spine is curved over. So what that's doing, again, if you think about the pictures that we had of the chest wall moving, it's just going to restrict the movement of the chest wall, which is going to restrict the airflow coming in and the airflow coming out. Let me see. Okay, just to introduce, that'll come up in the next slide, but how many people, by show of hands in this room, know about sleep apnea, or what sleep apnea is? Oh, wow, that's great. I should have someone else come up here. So sleep apnea is, it's much more well known than it was, let's say, 5 or 10 years ago, but this all comes into play. And we'll go over sleep apnea a little bit more in a couple of slides. Let me talk about vocal cord dysfunction. So some people may not think about this area being part of your respiratory system, right? The head and the back of the neck. But it is, and part of that respiratory function comes from your vocal cords opening and closing to let air in. And if there's dysfunction with one or both vocal cords, you are at increased risk for aspirating or accidentally choking on any food or liquid. And then the dangers with that as a respiratory therapist is that that contents may go into your lungs and cause some form of infection, which can then lead to more difficulties down the road. So if you were to come into the clinic, I would ask you and talk to you about signs and symptoms of shortness of breath. Very early signs are simple, and it can be very difficult because most of us here live in the Bay Area or elsewhere, and this day and age, we all lead very busy lives. But fatigue and difficulty concentrating are signs of shortness of breath or inadequate breath, not getting enough oxygen to your vital organs, such as your heart and your brain. Later signs include actual sensation of shortness of breath, also called dyspnea, or orthopnea, difficulty breathing when you're lying flat, okay, such as when you go to bed. And then also something that you may see more often in children called belly breathing, where you're seeing big movements of the abdomen while you're trying to catch your breath. So if you have any of these signs or symptoms, and then tying it back in again with CMT, proximal upper extremity weakness, this is something that I saw in the studies, that with patients with CMT who also had proximal upper extremity weakness, the incidence for having some sort of respiratory compromise was higher. So if you find yourself in that category, then what you want to do is talk to your clinic, have a pulmonary function study, which will also include maximum inspiratory pressure, that's what the MIP stands for, and possibly maximum expiratory pressure measurements. Other things that a physician or a clinic might consider is taking an arterial blood gas, and that's a blood gas sample. It'll come from your artery, not your vein. So that's the blood that's being pumped directly after it's come out of your lungs and it's been oxygenated. And what they're looking for there is to see what are your oxygen and your CO2 levels like? How is the body functioning? Also, overnight oximetry, which is tying back to the sleep apnea and how you're breathing when you're lying flat. Okay, and that, so they're looking for drops in oxygen saturations. They also may ask for a chest x-ray or fluoroscopy. If you'll see over on the right, any of those three boxes, if certain values are found there, you can go straight to treating that respiratory compromise. So reduced chest wall movement can show a deficiency in the diaphragm. If the diaphragm isn't able to fully contract all the way down, helping create that negative pressure and draw air into the lungs, then you'll see that when a person goes to take a big deep breath in, that chest doesn't fully rise and expand out. And then with a stethoscope, you'll also hear diminished breath sounds, or you might hear something that we call fine crackles, which is like Rice Krispies in the lungs. And that's just the lung itself inside the chest having to pop open with the breath. In the clinic, you can see over to the left is an example of somebody doing a pulmonary function study. So we like to do spirometry testing upright, and then if we see other signs or symptoms, we'll also have you lay down and do it flat. Because if there's a 30% change in your values from sitting upright to lying flat to lying back supine, then that is a signal of some sort of respiratory compromise or trouble with the diaphragm. We'll check your maximal inspiratory pressure, peak cough flow, and then again, we talked about the imaging and the labs. So I keep saying spirometry. What I'm referring to is something called a flow volume loop, and the MIP and MEP, and the other parameters. So I just want to take you through, when you come into the clinic, what to expect. I usually take, I would say, an average of about 20 minutes with patients to go through this, especially if it's the first time that you've been there, because we're talking through what it is that you're actually doing. So you can see there's a picture of me and one of our medical assistants in the clinic, and she's doing a pulmonary function study. So she's holding a spirometer there in her hand. There's a clean filter in a clean filter that acts as a mouthpiece also, and a nose clip. And really what you're gonna be asked to do is to seal your lips tightly around that mouthpiece, making sure that there's nothing obstructing the center of that filter. And you're gonna take a big deep breath in, You're not gonna hold your breath at the end, but you're gonna blow out hard and fast. And I ask you and I encourage you to blow out for 6 seconds or more. And that allows us to see what that magic FVC number is. Hard and fast for at least 6 seconds. And we're looking for a very strong effort. You may have had pulmonary function studies done elsewhere. One of the things that I love about working in the clinic is that spirometries can vary. They'll vary from clinic to clinic and from who you do it with. So we do them every time our patients come in so that we can establish a baseline and then see if any changes occur from there, because we're always using the same machine, and for the most part, I'm the main respiratory therapist there in the clinic, so those things are consistent. So we're looking, if for some reason it's difficult for you to hold that mouth seal, whether you're in our clinic or someone else's clinic, please let them know so that we can give you a different mouthpiece, because then you're not getting accurate numbers. And this is what we're seeing on the screen. This is your spirometry or your flow volume loop and your FVC. So there's 2 pictures here, pretty colorful. The black one shows a normal FVC. The bottom half is your inspiration, when you're breathing in, and then the top half is when you're breathing out. The bottom axis is your volume, and then your flow. So you can see on the left, the blue one is a restrictive flow volume loop. So a little bit smaller, less flow coming out. Over on the right is a more complex diagram that's showing normal emphysema, bronchitis, and pulmonary fibrosis. But if you look at the purple one, which is the smallest one in there, that shows restrictive disease. Restrictive disease is what's happening if your diaphragm is weakened or not functioning correctly, and if you're having weakness in those accessory muscles. So the FVC tells us about the volume that's being pushed in and out. But we talked about the diaphragm being a dome shape, right? And remember those 2 phrenic nerves, one for the left and one for the right. Now you could be a person that has involvement with one of those phrenic nerves, left or right, but the other one is functioning fine. And then you also have your accessory muscles, so that when you're walking around during the day, going about your daily business, you really don't notice much shortness of breath. You may always find a way to park closer, or you don't like taking the stairs, you take the escalators, or you take the elevator. Some of that might be tied to shortness of breath, but we just don't think about it in our mind because we're just getting through our day. So the MIP and the MEP, or that inspiratory and expiratory pressures, help us look more directly at the diaphragm. So here we have a mask. That mask covers your nose and your mouth, and there's a filter and some one-way valves. And what you're gonna do in a clinic is you're gonna be asked to hold this mask up over your nose and your mouth, take an easy breath in, blow out till your lungs are empty, and then take a big giant deep breath in, only you're not gonna get any air. It's gonna feel like you're covering your hand in your mouth with you're covering your nose and your mouth with your hand. And it's a very odd feeling. I always walk people through this very slowly. I've done it myself and my eyes popped out because you feel the pressure and that mask sink in because you're creating a negative pressure. But you wanna pull as hard as you can, and when you do that, you'll feel it in your diaphragm because that muscle is working against that resistance to come down. So that can give us, you may have had a normal FVC or a normal flow volume loop, but if your MIP and MEP are low, then that means your accessory muscles are taking over and doing more of the work because the diaphragm isn't functioning to its highest potential. This is just showing the upright and supine, and we talked about why those are important. So an FVC less than 80% of predicted shows some deficiency in the respiratory system, as well as a greater than 30% change in sitting versus upright, and a MIP less than 40 centimeters of water pressure will also be signs of abnormal muscle function. With that, we also talked about sleep apnea briefly, or I just mentioned it, but if you have morning headaches, daytime fatigue, frequent napping, difficulty breathing lying down, and the daytime fatigue is in particular, like if you wake up with a morning headache and you wake up still feeling tired, you never feel rested when you wake up, whether it's from the night before or from a nap. Those are signs of inadequate breathing at night. So we take all of this information, how you're feeling, how you're sleeping at night, and what your numbers look like. And from that, we put together a picture of what could possibly be going on. Things may look great, or it might look like in some areas, you could be doing better. And the reason you have a respiratory therapist there is to help tease that out and see where we can help to make life more functionable. I'm not sure if that's a word. So, positive pressure ventilation, those of you that raised your hands that know about sleep apnea, either you have it or a family member or a friend does, the biggest thing that we do now to help people with their breathing is positive pressure ventilation, otherwise known as CPAP or BiPAP. I just wanted to put this up there. These are the Medicare guidelines, which most other insurance companies go for initiating BiPAP or CPAP. So even though we see respiratory deficiency at 80% and below, they don't start BiPAP unless you have an FVC of 50% of predicted, unless you have some of these other signs, such as dropping your oxygen levels at night while you're sleeping for 5 minutes or more to 88% or below, or you have that inspiratory pressure is low, it's less than 60, or if they take a blood gas sample and they find that the CO2 in your blood is higher than 45. So that kind of ties into what will help. Even if you don't qualify for BiPAP, or it's not going to help you because maybe your respiratory compromise isn't that bad, there's still other things that you can do. So we like to start with deep breathing and coughing, and it sounds so simple, but I know you guys have been here at this conference getting great information all day, but we've been sitting most of the day, so our lungs are like this. And what we really need to do is afterwards, when you're all done, is go take a walk around campus. It's beautiful outside, and get that deep breathing in. When you're walking and moving around and doing activity, you're pulling more air into your lungs. And you need a good volume into your lungs to create a nice strong cough, which comes into, again, like that vocal cord dysfunction or the possibility of having secretions in your lungs. You need to be able to get them out to prevent infection. So deep breathe and coughing, hyperinflation, and then also for people that have problems clearing secretions out, whether it's because there's a lot of them, or they're thick, or they just have a weak cough, there are equipment that's out there to help you break up those secretions and make them easier to cough out, so you can get all that done in 15 or 20 minutes once or twice a day, as opposed to dealing with with a productive cough all through your day and having it be disruptful. And then, of course, the BiPAP. So I want to talk briefly about BiPAP and CPAP. There's both, and they're both used for sleep apnea or other respiratory insufficiencies at night. For most of patients with restrictive diseases, specifically patients with CMT, if your breathing dysfunction at night is coming from issues with your diaphragm, BiPAP is going to be a more appropriate choice. Not all sleep labs are familiar, or they may not think about this because they may be looking at you directly from a sleep apnea component. So sleep apnea can occur because this is your airway, right? So let's say I fall asleep at night, and if there's any plumbers in the room, you guys will get this. If I fall asleep at night and I go to take a big deep breath in and my airway collapses, it's causing an obstruction. So CPAP is one level of pressure, and what it will do is it'll open up and create a stent in my airway and hold it open so that I can breathe in and out freely without it collapsing. BiPAP, however, as you'll see in the picture, has two levels of pressure, one when you're breathing in and one when you're breathing out. So by doing that, it's helping you create that chest wall movement and that diaphragm up and down. So it's giving you breathe in, here's a pressure, and when you exhale, it doesn't hold it here, it drops it down. So your diaphragm's not having to work against that high pressure to exhale. If any of you have been tested for sleep apnea and tested positive, and you've been put on a CPAP and you're having a heck of a time tolerating it and it's difficult to breathe, it could be that you would be a better match for BiPAP, and you just need to talk to your sleep doctors, or your neurologist perhaps can help you communicate that to your sleep doctor. My guess is that you'll find it much easier to breathe on and you'll get more of a benefit. These are examples for those of you that aren't familiar with CPAPs or BiPAPs or sleep apnea. So you do sleep with a breathing mask on. Now, it can cover either just your nose or your nose and your mouth. It depends on whether you're a nose breather or a mouth breather. These masks have come a long way. So if this is something that one of your doctors talked to you about 7, 5, 10, 20 years ago, and you tried it and you said, no way, there's no way you're ever gonna get me to go to a sleep lab, I'm not doing this thing, they've come a long way. Please just go in and for your own sakes, take a look or look online. You can see the full face mask there in the center. You can see nasal pillows up here on the left. And down on the right, and then up on the left is just the nasal mask that covers just the nose. So it's a little fuzzy up there, but that chest x-ray up on the left shows, if you can notice, is there a difference between the left and the right side? Right, so one side, that diaphragm, is a little higher up. So one of the diaphragms is not working as it should. So this person may very well have no symptoms. They may go about their daily lives just fine. At night, perhaps they snore a bit. Maybe they have some symptoms of sleep apnea because of this, and maybe they're getting treated for it, and maybe they're not. My concern and the information that I really want to give across to you guys today is that it's important to get these things checked out, because if there's an illness or a surgery, and it can be any surgery, planned or unplanned, it could be a cardiac surgery or an abdominal surgery. When you put those things together with a respiratory system that is a little bit compromised, then you can have increased secretions, and then that can lead to increased infection, and it can kind of domino. So I think that it's important that if you're having symptoms, to go ahead and have it checked out and just see, what can I do to make it better, so that if I get a really bad cold or a flu, I'm able to clear this stuff out on my own, and then the infections don't last as long, and you'll be better off for it. So almost in closing, if you have CMT, especially if you have a history of proximal upper extremity weakness, and you have some signs or symptoms of shortness of breath, I encourage you, when you go into your clinic, when you see your neurologist, to ask about a pulmonary function study if they feel that it would be appropriate, and get evaluated pulmonary-wise. Especially if you are undergoing any sort of anesthesia, upper abdominal surgery, thoracic surgeries, to get screened. And as a respiratory therapist for 8 years, the biggest thing I've found across the disciplines, CMT, cystic fibrosis, congestive heart failure, is prevention is the key. Kaiser has their commercials on that. But there was another piece to this. Just blew my mind. Okay, well, let's see. Thank you. There was another piece.
Thank you.